Hi, everyone. Thank you so much for joining us today for this panel discussion on building trust in the healthcare system among communities of color. My name is Deanna Pan. I'm a reporter for the Boston Globe. As we all know, Black, Latino, and Indigenous Americans have suffered disproportionately from sickness and death throughout the COVID-19 pandemic. And yet, as this pandemic and our ongoing vaccination efforts have shown, mistrust in our healthcare institutions is rife. This conversation will address some of the root causes of this mistrust and solutions moving forward for repairing the relationship between medical providers and people of color, and of course, for creating a more equitable healthcare system. First, a few logistical reminders. If you have any questions for our panelists, please use the Q&A tool at the bottom of your Zoom screen. And keep in mind, this is a virtual event that will be recorded and distributed afterwards. Before we get started here, I'd like to introduce our sponsor, Dan Sensi, CEO and Managing Partner of Solomon, McCone & Sensi, for some opening remarks.
Thank you, Deanna, and thanks to the Boston Globe for its outstanding reporting throughout the pandemic. I'm Dan Sensi, CEO of Solomon, McCone & Sensi. We are a strategic communications firm providing senior-level counsel to healthcare, nonprofit, and corporate clients at the intersection of public policy and business. Thanks to all who are joining us here this morning. The COVID-19 pandemic has exposed health disparities that grew out of our country's long and shameful history of structural racism in medicine. Its legacy and lasting effects are pervasive across healthcare today, requiring critical work to reckon with that past and earn trust for communities of color who've been failed by the medical system. Over the past several months, community-based organizations, clinicians, and public officials have collaborated to advance these efforts, engaging with people about the safety and efficacy of COVID-19 vaccines while striving to improve access to it. As the vaccination rollout progresses, with Massachusetts about to fully reopen at the end of the month, there's still a lot to do to dismantle the inequities embedded in our healthcare delivery and establish trust in the process. Today, we will hear from experts leading these efforts about how we can build a better and more equitable healthcare system moving forward. Our firm is grateful to partner once again with the Globe in our shared goals to convene important discussions about how to address issues like these. Now, I'll turn it back over to Deanna to introduce our panelists.
Great, thank you so much. So first, I am just honored here to be speaking with three incredible panelists who are all experts in their field. We have Dr. Bisola Ojikutu. She is an infectious disease physician at Brigham and Women's in Massachusetts General Hospital. She also directs the Community Engaged Research Program at the Harvard Center for AIDS Research. Thank you, Dr. Ojikutu, for being here. We also have with us Michael Curry. Michael is the president and CEO of the Massachusetts League of Community Health Centers. He is also a member of Governor Baker's COVID-19 Vaccine Advisory Group and co-chair of the state's COVID-19 Health Equity Task Force. Thank you, Michael, for being here as well. And finally, we have Christina Alonso, the Health Equity Director for La Colaborativa in Chelsea, where she works to ensure that COVID-19 testing, vaccines, and social protections are easily available and accessible to the residents of Chelsea through the organization's grassroots outreach. And thank you, Christina, for being here as well. So I wanted to address our first question to Dr. Ojikutu, just kind of set the stage for why we're having this conversation in the first place, which is about this issue of trust and this lack of confidence. Dr. Ojikutu, where does this mistrust and lack of confidence in our healthcare system come from? And why is this a problem if our aim, as it should be, is to end this pandemic?
That's a really important question, and thank you, Deanna, for having me here with you today, and thank my panelists, because I really appreciate the work that you both have been doing, and I'm interested in hearing more about your opinions on these topics. Mistrust has really played a central role in this pandemic, and it's been undeniable. Mistrust in research, the pharmaceutical industry, healthcare institutions, and in the government as a steward of the public's health has really been heightened. I mean, I think it's always been there, sort of a baseline in some communities, but it's really been heightened. And I think that this baseline mistrust combined with the uncertainty, the misinformation, the disinformation that's out there, particularly online, as well as the messaging, which hasn't quite hit the mark in many respects. It's heightened this mistrust, and that's across many populations. But for Black, Latinx, and Indigenous folks who are twice as likely or more to die, which has been stated, and significantly less likely to be vaccinated, mistrust is really symptomatic of a more pervasive pathology, and that's structural racism. And I don't know that we need to go back in time necessarily to do a history lesson, but I think we do need to continue to look and recognize the current state of affairs. We have injustice, we have systems of privilege and power, we have disenfranchisement, marginalization, and minoritization. And really that's what structural racism is, and that's led to mistrust of these systems within communities of color, because these systems have never really proven to be trustworthy. I think, one of the things that I'd like to emphasize this morning, and probably what I would like folks to take away from this, is that mistrust is really a normal, rational, and understandable adaptive response, even protective, within communities of color to structural racism. And I feel like that has to be stated because a lot of the blame for this lower uptake of COVID-19 vaccines has really been placed at the feet of communities of color, as opposed to looking at the systems which started the process in the first place. And this is unfair, and I really think we need to contextualize the problem.
Great, thank you so much, Dr. Ojikutu. Michael, this next question is for you. Community health centers have always played a critical role delivering healthcare to historically underserved populations, including the working class and people of color. What are the biggest lessons from this pandemic that you and your colleagues in community health have learned about your patient population and what their needs will be moving forward?
Thank you, Deanna, and thank you to Mr. Sensei and the Boston Globe and others who helped organize this important and timely conversation. I think most importantly is I always reflect back to the fact that community health centers were born out of the civil rights movement, born right here in Boston. The first health center was in Columbia Point. The second health center was in Mount Bayou, Mississippi. The founders of that movement in the 1960s, when we Black and brown doctors couldn't gain access to our medical institutions, when Black and brown patients were being turned away at hospitals across the country, and there was a civil rights movement afoot in the country, there were architects like Dr. Jack Geiger, Count Gibson, Dr. John Hatch, and Dr. Smith, who led a movement to create a community health center that would provide access for people across the country. We can't lose sight of that in the moment, because quite frankly, why they created it in the 1960s is why we need it in 2021. They knew that the people closest to the pain were those people in Southside Chicago or East St. Louis or Roxbury or Chelsea. They knew that you had to create boards where the people sitting at the table, over half of the people sitting at that table should be the consumers, should be the people that were patients of those health centers, which is mandated in the community health center model. We learned a lot in this last year. I think we learned a lot, and society learned a lot about us and the communities we serve. We learned that technology matters as we pivoted on a dime to embrace telehealth. We went from 0 telehealth visits during the early outset of this outbreak in March to 60% over the last year. We were trying to encourage, along with the hospitals, trying to encourage more use of technology. But this pandemic forced us as a society to embrace it, to provide the regulatory relief, the funding, to get the technology in hand to do the kind of care that brings care into the homes and places where people are that need that care. Society learned that health centers are critical. Our patients know that. The communities we're in know that. Quite frankly, we're the communities where, if you looked at it on a map, we're the hot spots, both here in Massachusetts and across the country. As you saw COVID-19 playing out across the country. Those hot spots, there's a health center there likely. And society learned that we need our health centers because we speak those languages. We can engage the people in our waiting rooms. In many cases, the people treating you and providing care look like you, sound like you, may share your cultural background. So I think there's a huge lesson we learned as a society overall, that we can do great things when we try to do them together. And I think you saw these collaborations between community groups, faith organizations, community health centers, government with Governor Baker and Secretary Mary Lou Sudders and DPH Commissioner Monica Burrell. Many of us came together, and community activists like the Boston Black COVID Coalition or Morning Star Baptist Church. That's the lesson we should take from this, that we can solve disease, we can eliminate health inequities, and we can really make change both here and across the country when we do it together and we do it with some intentionality.
Okay, great. Thank you so much, Michael. Christina, this question is for you. Through your work and your research, you have witnessed the devastating toll that this pandemic has taken on the health and well-being of Chelsea's residents, particularly on the immigrant and Latino community. Yet according to the most recent available data from the Department of Public Health, just 42% of Chelsea's Latino population has gotten at least one dose of the COVID-19 vaccine, compared with 72% of white residents. What are some of the challenges or barriers that you have seen that may be preventing Chelsea's Latino residents from getting vaccinated? And how can these barriers or obstacles be overcome?
Thank you for that question, and thank you for inviting me. Thank you for my panelist. It's great to be part of this really important conversation. I think one of the things that we kind of, to take a step back, is that what La Colaborativa did in response to the pandemic, which is exactly what Dr. Curry was just talking about, was listen to and respond to the immediate needs of the populations that we're serving. And so in terms of vaccine access, La Colaborativa obviously has never provided vaccine access. We were working on very different things. And like many of us, we had to pivot to address many of the needs that have come up with the pandemic. And so one of the things that happened was figuring out how to make sure that Chelsea residents had access to vaccines, especially during once we got off the ground in February. And I'd say the first thing that happened was that access initially was through websites and through phones, right? And so residents were expected to be able to have the technology, the language capacity to be able to go onto a website, make an appointment. We all know how difficult it was to make those appointments online. So what we did at La Colaborativa was really quickly, we realized that these two ways of making appointments were not relevant to our population. So what we started doing was collecting lists of names of people who were eligible at the time. And so we have outreach workers, we have the food pantry lines, we have the diaper lines, we have a series of ways that we're interacting constantly with the community. And we were constantly hearing people saying, I tried calling and I was on the phone for 40 minutes. When you're an essential worker, you don't have 40 minutes to wait for somebody to answer the phone. You certainly don't have hours. Many of the people we were serving could not navigate the website for making appointments. And we were also really focused on trying to get people appointments in Chelsea. We know that there are people in Chelsea at this point who cannot afford the bus to Boston to get an appointment at one of the larger centers. So what we started doing was just collecting names. And what we would do, we would collect between 300 and 400 names of Chelsea residents every week. And we would send those names to the East Boston Neighborhood Health Center. And we would call those people back and locate an appointment for them during the hours that they needed. This also required renegotiating the time. So we've opened up weekend clinics, we've opened up night clinics, because again, if your vaccine clinics are open from 9 to 5, that's irrelevant to a lot of essential workers. We need better hours that actually serve the times that they're available. The other thing that I think was a huge barrier initially, which is very much reflected in the Chelsea numbers, is the age eligibility requirements. So we know that until April 19th, people who were under 55, under 65, are essential workers, which is really where the COVID pandemic was in Chelsea after the initial surge in the nursing homes in July. we definitely saw the pandemic shift into essential workers, and that's where it's remained. Definitely in Chelsea, your COVID positive rates are going to be around people in their 30s and 40s. And it wasn't until April 19th that this cohort was able to get a vaccine, able to get an appointment. So we really pushed from the start. From January, we were really pushing for a policy to consider that in certain communities, young communities, Chelsea's a young community. Most Latinos that come to the US are young because they're looking to work in the US. And so we were really pushing for the age eligibility requirements to be reconsidered or to even be opened. This didn't happen until April 19th. So we do have a lag of 2 months, maybe even 3, of the majority of our residents actually being eligible to get a vaccine. So since then, since we've been able to open the eligibility requirements, we've continued to do on the ground. I will tell you that more or less every day I process between 20 to 50 appointments. What's happening is my healthcare workers are on the ground going door to door in the squares, hanging out in barbershops, going to the supermarkets, and directly talking to people. What they do is they collect a person's information, they pass that on to me, and we have a backdoor system where we can set people up for appointments right away. So people on the street are getting appointments. This is how we've been able to solve it in a very grassroots, direct way. And the third thing, and I think that, this is what both of my other panelists have talked about, is the structural racism. We cannot forget that this initiative is coming on the backs of public charge and of many years of absolute, very specific discrimination against people who might not be documented, whose residency requirements are confusing, whose access to legal, any sort of, healthcare benefits might be conditioned over the other benefits that they accrue. So there's a lot of confusion in the Latino community. Can I apply for unemployment? Can I get a vaccine? We've had people say, I don't have an ID. How do I show up? I've been asked for health insurance. I don't have health insurance. I got scared and hung up the phone. People are scared that when they're asked for their personal information to sign up for an appointment, they might have ICE show up at their door. These are very important trust-based issues that inhibit people from being able to openly show up at a health center and say, this is who I am and this is what I need. And we're doing a lot of community-based education to really inform the public that you're not gonna, all your information's private, nobody's gonna ask you for anything. But it continuously happens that people are asked for their information in order to book an appointment. And this violates the trust again. It re-traumatizes people in a process where they're already terrified and they're already scared that anything that they access, any social protection, is going to impede their capacity to be safe in this country.
Christina, you brought up so many amazing points just now. I have a few more questions. These are for all of our panelists, and then I hope we'll get to some questions from our audience here. My first is around the federal government and of course the CDC's public health messaging around COVID-19, the precautions we should be taking, even the development of the vaccines, which I think many have criticized as being, either unclear or constantly evolving and difficult, I think, for people and the public to make heads or tails of. And for any of the panelists here, my question is, how can public health leaders, medical providers be better communicators in the event of another outbreak or crisis, especially when communicating these messages to communities of color who may be more, as we've been discussing, hesitant or mistrustful in the first place?
So maybe if I can start, Deanna, if you don't mind, and really echoing some of what has already been said. Quite frankly, communities need to have ownership of the messaging. They need to have ownership of the overall pandemic response, but they need to be guiding how to disseminate and how to speak to the people who they know, because that's their community. They need to be central to all that is happening, and that really hasn't been the case. They haven't been so-called at the table since the very beginning. I think, secondly, we know that from the data that we have out there that, healthcare providers, particularly Black and Latinx healthcare providers, Indigenous folks who are from those communities, are really trusted messengers. And I would include in that group also, community leadership. I mean, as Michael mentioned, there are a number of people here in Massachusetts who may not be healthcare providers, but they're trusted within their communities. I think that one thing that has developed that I think I'll just say needs to be sustained and maintained is this idea of these trusted messenger programs, in which you have diverse healthcare providers and others communicating evidence-based data, debunking myths, and really trying to build the trust regarding COVID-19 vaccines. My concern is that, unfortunately, I'm not sure that this is going to be sustained and maintained over time, that we're just sort of going to drop this, when everything, everybody becomes unmasked and everything feels like it's back to normal, quote unquote. The reality is that people of color who understand their community should be leading the fight, leading the way in terms of addressing disparities and doing the communication and leading the efforts and being compensated to do so across all of our disparities. This shouldn't just be something that we're doing just as a pandemic response. This needs to be something that's integrated into our system. This is, again, about structural racism. This is about workforce diversity. This is about access. This is about getting opportunities to lead. I've seen it. We've all seen it, on television. We've seen providers of color. We've seen people of color leading. That needs to continue, and that's something that I certainly am worried about. And this idea of communities having ownership of their own messages, that needs to continue. I mean, communities really need to be central to any response to problems within their own communities. They need to be central to the dissemination of messaging, development of messaging, scaling up of vaccination. Organizations that are empowered, like the Black Boston COVID Coalition, like La Colaborativa, they need to continue. This can't just be about COVID-19. And it certainly hasn't just been about COVID-19, but it really is about empowering them and funding them directly to continue to be the boots on the ground, to be working in their own communities, to doing the work and combating the misinformation and the disinformation that's out there. It's one thing to think about things federally, but I think we really need to hone down into what's happening on a local level. And I do think that we need to continue to empower people to be leading this process.
If I can add in there, so one, every time I listen to Dr. Ojikutu, I'm so thankful that she's here in Boston. And I think about, people always come to me and say, well, Dr. Fauci, I listen to Dr. Fauci, or I'm following Dr. Nguyen, these names and faces that people see on television. If you are listening on this call today, be very thankful that you live in New England and in Boston and Massachusetts, because we have our own Dr. Fauci's here, Dr. Ojikutu being one of many, or Dr. Chandler. We have a wealth of folks who are on the ground, who understand this disease and health inequities, and to help leading the way. So to your question, Dean, I think on the federal Dr. Ojikutu reminded me of a chant that's come from the streets during this George Floyd moment, right? During this pandemic health inequity moment, which is nothing about us without us. Mm-hmm. So if you want to talk about how to do testing and contact tracing, you want to talk about how do you message around hesitancy, if you want to talk about how to distribute vaccines equitably, don't do it without us at the table. And us is that broad term, right? We know that early in this disease, they were going to make a decision here and across the country to determine who got a ventilator based on chronic conditions. That would have been an epic failure in public health. That would have been a major health inequity, but for people sort of lifting up their voices. Massachusetts Public Health Association, Healthcare for All, many of those other organizations here and across the country who are chanting, no, we need to do this equitably. And people listen. So I just want to acknowledge that oftentimes the progress comes from the ground. It doesn't come from the top. I think there's another piece to this around the federal government. I have to remind people we're in the middle of a pandemic, because I think sometimes people forget that when they want to take off their masks, they don't want to socially distance. They feel like the government is intruding on their personal lives. This was a disease that has killed over, I think, Dr. Ojikutu, across the globe, over 3 million people. That's a little less than the people who died during the Spanish flu in 1918. I think we reached 5 million people in 1918. So we are well into this disease. And I think we have to remind people that government and we are building it as we fly it. Mm-hmm. We're trying to figure out how to respond to this disease. What's the right protections? What are the right interventions? What's the right messaging? while I acknowledge that we're in the middle of a pandemic and we're figuring it out, I also got to challenge us to do better. And when I say us, I mean all of us, our healthcare system, our government, because in some ways we failed. I argue all the time, we defunded our pandemic response. We should have been better prepared with PPE. We should have been better prepared to communicate and coordinate between providers and health plans and government and community. We did not do that very well. Let's own it. Let's own it and let's do better. But Deanna, I think I'm hopeful because of folks that we have on this call today, and hopeful because of my good friend Steve Walsh at the Mass Hospital Association and Dr. Betancourt with MGH, who does work around health disparities, with the legislature, who's leaning in to start talking about a health equity proposal out of the legislature. I'm hopeful that this is more than just a moment and maybe a movement to really deal with some of these underlying issues.
Great, thank you so much, Michael. So as you kind of jumping off from that question, when we think about the policy interventions that might be useful at the local, state, federal level, what might those look like? What will be necessary if we want to ensure that the communities that have been disproportionately harmed, whether that's through their health, through their finances, can recover from this pandemic?
I'd like to start by addressing that question. I think it's a really important question, and I would really say two things. The first thing goes back to the chant of nothing about us without us. And I think one of the things that grassroots organizations are really good at, something that La Colaborativa is really good at, is being able to respond in the moment. The fact that we're small, the fact that we're local, the fact that we're on the ground means that we're constantly listening to what people are saying. So for example, I meet with my group of health promoters every Monday, and we talk about, what did you hear this weekend? Mm-hmm. What are people talking about? The myths, the fears, the concerns about vaccines, about COVID, about masks, about, whatever's coming up in policy, what they hear on the news, what they hear coming down, sort of the larger pipes, people are digesting that over the weekend. And so what we do is we come together on Mondays and we say, what did you hear? What are people talking about? A very specific example, we're in the middle of allergy season. People are having a really hard time with the pollen right now. And a huge concern is, can I get a COVID vaccine if I have allergies to pollen? This may seem insignificant, but this is huge. This is a really big question that needs to be answered. And this is what we do every Monday, is we troubleshoot these questions. So what's happening on the ground is we're able to listen carefully. What are people talking about this week? What are people talking about today? We all know what happened when, for example, Johnson & Johnson came out with a research on, coagulation, and people started freaking out about, can I get any vaccine? Am I going to die? These are very immediate concerns that because we're on the ground, we're able to go right back out onto the streets and say, okay, this is what we need to talk about. The other thing is that the people that are on the ground are from the community. And so these aren't, fancy people who are coming in from another state or from another country who are saying, you really need to listen to this. These are local people who are going to the same churches, the same stores, that drop their kids off at the same schools. These are your local moms, And so being able to be part of the community and understanding, what are the values? What are the priorities? How are people making decisions, both in terms of their money, in terms of their time? What's important to people in a community, I think, is what really guides community response to be so efficient. And so I would say that at a state and a federal policy level, it's enabling us to be able to do that work. So really trusting, if we're trusted as community members and community outreach workers, we can do our job well, because then the community will trust us. The other thing I would say is that we really need to get better at listening to what's going on the ground. So oftentimes, we'll hear people say, I often hear people say, well, all Latinos are scared of vaccines. That's not true. Not all Latinos are scared of vaccines. We need to be a little more nuanced on how we generalize about communities of color. We tend to group communities of color into one massive group and say all of the communities are behaving this way. That's not necessarily true. And if we do a better job at listening to who's on the ground, who's working with those communities, who really understands, and listen to what are the differences, the concerns that one group might have are not the same concerns that another group might have. And so we need to constantly be very humble in what kind of assumptions we're making about communities of color and make sure we're listening to those communities so that we can create policy with the communities that's relevant, makes sense to them, and is applied. And the last thing I'll say is that for any person who has a family, anybody who's navigating this pandemic, is that any policy response needs to be wrapped around everything that involves your life. So when we have policy that only addresses, for example, housing or only addresses vaccines, it doesn't help people in the way they really need to be helped. Again, one of the things that we've done at La Colaborativa is we listen to what people need and we adapt our programs to their needs. So yes, we deal with housing. Yes, we deal with evictions. Yes, we deal with food. Yes, we deal with diapers and sanitary pads and domestic violence and vaccines and testing and everything, because these are all of the things that have come up in the pandemic. And as we grow through this pandemic into hopefully a better understanding of the social determinants of health, we'll be able to continue to focus on wraparound services as a much more holistic solution to the problems that communities of color are having, instead of just focusing on diabetes or asthma. Really understanding that health is the result of a whole group of factors that are continuously happening to people.
If I can, Deanna, just to reinforce one point, Christina, thank you for the tremendous amount of work that you've been doing along with the organizations. I'm a fan, and I just want to say, for those who are listening, this is the kind of people and organizations you should be recognizing, because these are the people who meant the moment. And I think for all of us who've been watching these collaborations, this leadership, one of the things she said I wanted to reinforce, community health workers, the canaries in the coal mine. These folks who are on the ground, speak the languages, know the communities. They've been working with Christina and her efforts. They're working with community health centers across the state. The Secretary of Health and Human Services has resourced health centers to deploy more of them, to train them. That is an outcome of this pandemic that we should all celebrate. That we've now recognized that if you put the power, the resources, and the information in the hands of the people who are closest to the community, you can do great things. And I think I just want to take this moment with Christina's comment to lift up community health workers as key to addressing the short-term and the long-term impacts of this disease. Because we know that this is not just about reopening. For the communities that we all serve, this disease will still have impacts economically, health, and in other ways for months and years to come.
Can I just add to that, Deanna, if you don't mind, because Michael and Christina have hit on such important points, and there's one piece of that I just want to hone in on. You know, we have outstanding communities and communities that are empowered in this city. We have outstanding healthcare institutions, outstanding academic institutions. We have an outstanding public health infrastructure. We have social services, we need more of them, but what we have is good. What we need to be doing is working closer together. We need more cross-sector alignment. We have a shared vision. I believe we all want a culture of health in the city. We need to share our resources. We need to share our data. We need to stop working in silos. We need to be integrating, and communities and community health workers really need to be at the center of that. So I really love to see, walking away from this epidemic, walking toward that light at the end of the tunnel, that we are more aligned and integrated. I think there are so many things that we could do if we work closer together.
Michael, since you brought up in your last comment, this issue of reopening, are any of you have any concerns that Massachusetts might be reopening too soon? And how might this accelerated timeline affect these kind of predominantly, Black and Latino cities and towns that have been hardest hit by this pandemic and yet remain comparatively under-vaccinated?
Yeah, maybe a quick comment on that. I think it's interesting. I've lifted up with others, many others, this issue of lives over livelihoods, or the dilemma, conflict that happens between public health and politics. And we've seen it play out a lot over the last year, right? People are worried about economies and restaurants and bars and name those things. But then I couldn't help but think about, what about those lives? And I just want to take this moment to readjust us to the fact that this should always be the North Star for us, which is saving lives. Everything else can work itself out. That being said, I think as we're looking to reopen, I'm concerned about those communities that are still seeing higher rates of infection, and those communities that will see potentially other outbreaks because of the lack of uptake of the vaccine, and the economic and health impacts. As Dr. Ojikusu knows, we're still trying to determine sort of that long-term health implication of COVID-19 on some of our patients. So we have a lot to figure out. So I am nervous as we think about our reopening and what it means for Chelsea and Lawrence and Lynn, Springfield and Worcester. What it means is those communities could see other forms of outbreaks and other forms of impacts as others get back to their lives. So I am concerned. I'll be watching it along with others who are on the state level, and then we'll be ready to ring that alarm when we need to do whatever mitigation strategies that will continue to save lives.
I would say that I would absolutely agree with Dr. Curry, and in Chelsea, we're very concerned. We're not very sure that this decision was based on data that's relevant to us and to our daily lives, when we still don't have the assurance that the majority of Chelsea are going to have had a second dose and the 2 weeks afterwards needed to ensure immunity. And now people are taking off their masks. People can go back to a restaurant. People can go to any space without using a mask. The people who are most going to be affected by this, obviously, are the essential workers that live in Chelsea, that live in Everett, that live in Lynn, that live in Winthrop. So I think our concern is, are we going to now monitor that the cases go up and then we're going to shut down again? And then, how many more months can we sustain social protections? How many more months can we expect people to go back into their houses? The relevance of this is that in Chelsea, and I've talked about this throughout the pandemic, we cannot expect people to be able to socially isolate in overcrowded conditions when we have 15, 18 people in a 2 or 3 bedroom apartment. This is absolutely irrelevant. When we ask people to wash their hands, we're assuming that they have access to a bathroom 24 hours a day. This is not true in Chelsea. People take turns for using the bathroom because of the way that their rental system is working, because they're renting a room and they might not necessarily have access to washing their hands. These are very basic assumptions that assume that people are living in nice houses where there's running water all the time, that maybe we think, oh, well, that only happens in very low income settings. That's what's happening in parts of our state. And we really need to consider that. So I think that given that the essential workers, the immigrants, the communities of color were hardest hit, we're very concerned that this mandate has come once again without consultation to the communities that have been most affected by the pandemic.
Dr. Jakuta, did you have any, thoughts about that from an infectious diseases kind of perspective? But what this means?
Right. Honestly, I have to say that I'm concerned, like everybody else. I would say that what I'm most concerned about is inclusive of everything that's been said already, but that this move will not necessarily promote increased vaccination. What it'll do is it will decrease the urgency to be vaccinated. And that's just me understanding people, and understanding human nature. I'm worried that people will think that this crisis is over. It's not. And I think that if anything, this is a time to redouble our efforts to increase access to vaccination, to increase all the other services that people need. We have to continue to press forward. And that's really what's burning, sort of in my head. I'll also say that some of my colleagues and I at the Brigham, at MGH, and at Tufts, we did a analysis looking at disparities in vaccination. And this was recent. And they're there. We know they're there. They were on the front page. This paper was picked up by the Boston Globe, and thank you, Deanna, for helping to promote that. And it was out there. I mean, the disparities are clearly there. We have work that remains to be done. So I'm really going to be, focused in on what's happening next, and trying to encourage everybody who I encounter to be vaccinated. And we just have to keep working hard. All of us on this panel and everybody else who's out there doing this work, as Michael mentioned, we need to just keep doing the work.
Great. I know these past 14 to 15 months have been incredibly stressful for millions of people grappling with death, sickness, social isolation, hunger, evictions. What are some of the post-pandemic consequences that you all are most concerned with, particularly when it comes to, these people who we know have been disproportionately affected by this pandemic? And how should our health systems and various institutions be preparing for these consequences?
Maybe to add, and I think Christina and Dr. Uchikutu would agree with this, I'm concerned about the people who did not get care over the last year, who may have not come in for their dental care or their eye care, or their to treat their chronic conditions, who sheltered in place and who are afraid of contracting this disease. I think we should all be concerned about that and making sure, and as we as the health center community are engaged with our patients to get them back into care, that concerns me. I'm concerned about the underlying conditions that create health disparities, as we now have popularized and know this term as social determinants of health, that if you don't have a job, if you don't have transportation, if you live in environmentally unsafe communities, a whole list of those issues that advocates presented to us at the Health Equities Task Force that the legislature created, we haven't addressed those underlying conditions. So what it meant was, going into this pandemic, we already had a health equity deficit. We already had a challenge that's now been exacerbated by the disease. So we now need to really take an account of how much our communities that are most vulnerable are even more vulnerable in this moment. That's some data and research that needs to happen immediately. I know we in the health center community are trying to do this, but I think across our entire health center, our entire healthcare network, we need to figure out how much ground we've lost, because we've been trying to eliminate the taint of, quite frankly, race, as Dr. Ojikutu talked about, the taint of race in our healthcare system. And this set us back. I would argue it set us back significantly. And we now need to be increasingly intentional in the funding and the resourcing and the policies that we choose and the legislation we choose to move us forward and take the opportunity of this disease to really move us forward in a way that will address that history.
Can I add to that, if there's time? I wanted to speak to the issue of mental health and behavioral health, substance use. There's no question that this pandemic has negatively impacted people's mental health. And it's also created new barriers, as Michael mentioned, people who already had issues, with both mental illness and substance use disorders. There's been an increase in substance use that's been documented as a way of coping. There have been overdoses. In terms of overdose increase, that's been documented. More people are reporting anxiety and depression. I think we're experiencing collective trauma. And that's really due to what's happened: the loss, the isolation, the threat, the anxiety, locally, nationally, globally. And so, what do we do about it? I think Michael is absolutely on point with being intentional about our funding. We need to increase access to behavioral, mental health, substance use disorders, as well as all the other non-communicable. So your other diseases that Christina mentioned, you mentioned the diabetes and the wraparound services. We need to focus in on our health and wellness, our well-being overall, comprehensive. This needs to be an urgent need, just like vaccination needs. This is an urgent need. This is an urgent need. I also think, going back to this issue of mistrust, which is why we're here, is we need to normalize engagement in particularly mental health, behavioral health, social services, destigmatize the use of these services, destigmatize substance use across the board, destigmatize mental health disorders. And within our communities, we need to talk about trusting these systems. We need to talk about how do we get people to engage. And that part of that, again, is increasing access to it, normalizing it. And I think that's going to be incredibly important as we move forward. In addition, you mentioned, Deanna and Michael, this issue of sort of post-COVID sequelae. So what is going to happen to those people who were infected with COVID-19 and have had long-term side effects, across the board? I see a number of these patients and have seen them in my practice. They are going to have needs both in the healthcare system as well as public health and community, to support them. So, you know, thinking about this broadly, we have a lot of work to do, and the funding needs to be there to do it. I think that I do believe that people see this, but I want again to emphasize that there's an urgency to all of this. There's a piece of this that's the here and now with vaccination and making sure that, you know, that's obviously increased, but there's also the visionary piece, looking forward to the future. What is it we need? What resources do we need to really move things forward as far as, you know, a lot of these issues? I think it's incredibly important.
And if I can add to what you've both said, you both hit on all of the points that were on my mind. And the one thing that I would say too is that one of the ways to also implement this that might be different from how we've always done it is to actually take into account how is it that we provide these services. So currently, for example, if you have a mental health issue, there's probably one model. You go to therapy, you explain that to somebody. And what I found in my research is that yes, there's a lot more anxiety and depression, fear, re-traumatization, et cetera. People don't want to go to some person that they don't know, whose language they may not speak, whose cultural values they don't understand, and sit on a Zoom computer when you've got 3 kids running around the house, your mother-in-law asking you, you know, this does not make sense culturally, and it doesn't make sense to a lot of communities. So I think now's the time that we can re-examine how is it that we provide services, not just that we provide them, but how do we provide them in a way that builds trust, that's informed by local values, local priorities, that's informed even by what time people can get these services. You know, we have many, many models, and this is going to have to be, again, very local, very grassroots informed, where we can say, okay, does it work for Latino women to come together and talk about these issues? Does it work to do it in a church instead of a hospital setting? Because maybe that's, you know, that causes fear. These are the kind of questions that we need to start asking ourselves from the provider perspective of how are we going to make services so that they're safe, so that people trust them, and that people feel that they can actually grow and work through all of their issues in ways that are relevant to them. And now's the time that we can hopefully start to re-examine these issues.
And Christina, mobile, right? Pop up. I'm so proud of us that we were nimble enough to embrace mobile healthcare and start to deploy that in communities and neighborhoods, because they don't always come to a facility. So how do we bring healthcare to them, whether they're a senior or that person who's been traumatized by public charge and its anti-immigrant policies? I think we should be proud of that. Last, Deanna, but not least, Christina, I am not brave enough to be a doctor like Dr. Ojikutu. I'm an attorney. But I just wanted to set the record straight that I am not nearly as brave as she and those others that, quite frankly, are superheroes in this moment. I hope we don't lose sight of that they went to work knowing that they were risking their lives to provide care for our families. And then they were risking their families' lives. I don't want us to lose sight of that, because just like we don't respect our teachers, we don't respect our healthcare workers. And I so appreciate and humbled by them. I was in the airport recently, and people applauded as a physician walked through, like we do our military. That gave me chills just to see that.
Thank you, Michael. I really appreciate that. I wanted to say that I remember during the height of the pandemic, I walked into a store. I had my white coat on. It was a fresh white coat, actually. I was in the morning, and I had a jacket on over it, and people were literally like running away from me. I'm not kidding. That's the stigma that some of us have had to face. And I would just want to highlight that I do think that we have to highlight and emphasize and really congratulate not just our healthcare workers, but our essential workers, you know, the people who are hitting the streets every Saturday still. I know La Colaborativa is knocking on doors every Saturday. I know Black Boston COVID Coalition, they're not taking Saturdays or Sundays off, you know? So it's just been amazing. And this is the thing that I say is something beautiful that's come out of this. It really is. If you think about positive things moving forward, we have to somehow, you know, acknowledge people, but then keep up this momentum in some way and keep, like I keep saying, fund it, resource it so that we can keep doing this work.
Thank you guys so much. So I just wanted to bring up a few questions from our audience since we have a few more minutes. The first one involves medical education. And I'm also thinking too about, you know, the fact that we have, as I recently read, kind of historically low levels of, you know, Black male doctors, for instance, enrolling in our our medical schools. How can we, this question is from one of the audience members, inspire educators at the world-renowned Boston Medical and Nursing Schools to include minority health in their curricula and insist that this information be included in medical nursing education textbooks?
Well, I can start, but I'd love to hear both Michael and Christina's input on this, because I think people external to that system are also incredibly important to informing that system. I actually believe that people have been inspired. You know, I have seen an increase in what's being taught at both the medical school and then sort of the training levels, efforts that are, you know, sort of ongoing. They're getting going. I think I've seen much more of that than I experienced. And I was at Johns Hopkins in the middle of East Baltimore in the late 90s. Okay, so I know that there's been a change. There's clearly been a shift. What I would say though, even let's put trainees aside for a second. Let's talk about the doctors, the nurses, the clinicians who are out there, because they need to be trained too. You know, they need to be reinformed. This idea of healthcare providers acknowledging medical mistrust as a result of racism, having a better sense of what patient-centered communication actually looks like, listening to people's concerns, not immediately correcting everything that they say, listening and showing respect for who they are and where they come from, responding transparently to questions. That doesn't happen in all medical interactions. So I guess what I'm saying here is that we have work to do, certainly at the trainee level, but I don't want to leave folks who are out there practicing out of this process. We have a lot to learn.
Great.
I think just to, and I'm not going to comment on medical education, but I'm going to talk a little bit about, you know, when we think about a pandemic or we think about disease, we tend to think about a doctor. And we think, and when we think about a doctor, we tend to think of that as somebody who's, you know, very educated, very privileged, usually white, usually male. And I think one of the things that that we've talked about today is really expanding our understanding of what healthcare is. And health is something that you do to yourself every day, every moment, every time you decide to eat something, every time you decide to walk somewhere or go somewhere. And that interacts with the environment that you're living in. So I think one of the things that we could do is also start to inspire all people in all communities to become advocates for their own health and advocates for their community's health. And, you know, we've talked about community health workers. I'm working with a group of 14 women right now who may or may not have finished high school, and they are incredible, incredible health promoters, incredible, because they know what's going on, because they've lived it in their own bodies, because they're part of families that are being affected by what's going on. Every kind of allied health worker, we need more nutrition experts, we need more midwives, more nurses, more community, every kind of piece, so that we don't load it all onto the doctors, and so we don't expect doctors to solve everything, but that we also understand that this is part of our collective responsibility that we can all participate in. And I think that's something that we can do in communities to make health more relevant to communities, and not something that happens after you're really, really sick and maybe you figured out health insurance, and with a lot of fear and shame, you go to the hospital to ask somebody for some help.
And just one quick add on that, Deanna. So I'd be remiss if I didn't say the work that community health centers do with our medical schools to create a primary care pipeline, how critical that is, and a diverse pipeline. Two, I just want some quick shout outs. Derry Chassel at Harvard Medical School and at MGH, who invites me all the time to speak to her class, her young residents in psychiatry around racism and the medical field. And she's inviting in guest speakers like that. I want to credit Karen Emmons and the team at the Harvard Chan School for creating an entity to be a community coalition for equity and research, so that community people are at the table to meet with researchers as they're developing research. These are the kind of cutting edge things that we need to move this forward. And there's some people doing it. MGH had me do recently throughout the whole system, as did Children's Hospital and Brigham's and Women's, a presentation on the history of anti-Black racism in the country. That wouldn't even have been possible 10 years ago, where they would get their entire network to sit to a conversation, Dr. Koji Kutu, on what was slavery and what was Reconstruction and what is Birth of a Nation and who is J. Marion Sims. We are in an interesting time period now where there's a chance for us to have honest, critical conversations about the past and the present and how to move it forward.
So this last question, before we run out of time, is about issues of mistrust around the COVID-19 vaccine, particularly among Black Americans. This questioner asks, why don't healthcare professionals address these concerns of side effects, these serious side effects that we've heard about related to the vaccines? And why don't they try to value their concerns about the vaccine safety? Do any of you have any thoughts on this or advice for how healthcare providers can communicate to their patients about the safety of the COVID vaccines and their side effects?
Well, let me jump in and say this relates to everything we've been talking about, in that, first of all, it's not just about what happens between the patient and the doctor. I know that doctors and healthcare providers are trusted messengers, but a lot of this work regarding the safety and efficacy of these vaccines, this information is being spread on the community level at this stage. It's being spread by community health workers. I overheard a conversation outside of Dunkin' Donuts, two young Black men, they were a little bit older Black men, a couple of weeks ago, talking about the vaccines. So there has been an increase in health literacy. This is not about messaging that's siloed in one place or that needs to fall all on the shoulders of the healthcare system per se. And I think that's what we've seen, that this is really a bigger, broader spread and dissemination of information. And that's one of the things that, as we've said, needs to continue. We need to be talking about diabetes outside of the Dunkin' Donuts. We need to be talking about all of the other things that are happening. I would say, though, that, first of all, the vaccines we know that there's good safety data regarding the vaccines. And I would say that, as I mentioned before, this issue of how you communicate to people, how you address people within the setting of an encounter. And I don't care if this is a doctor doing it, nurse doing it, healthcare worker doing it, whatever. Listening to them, hearing what it is they've heard, talking to them, having a broader conversation than just about the blood clotting that they've heard about the J&J Janssen vaccine, really hearing knowing what their issues are. So understanding and respecting who they are, where they come from, speaking their own language, being a person who's racially and ethnically concordant with them, being transparent about what we know versus what we do not know. I think that is what builds trust. People want to hear that. So I think that there are many strategies that I've been talking about, that others have been talking about, and I think that a lot of this is what I believe is actually happening. It needs to happen on a broader scale.
Okay, great. Anyone else? Otherwise, I think we are just about out of time. So Dr. Jakutu, Michael, Christina, if you have any other points or issues that you wanted to underscore as we kind of close out this panel, I would invite you to do so. Otherwise, again, thank you so much, everyone, for joining us. I hope you found this conversation helpful and inspiring and give you something to think about moving forward as we try to confront the consequences of this pandemic.